Welcome everyone on this new seminar sponsored by Oculus, maker of the Pentacam. It's my great pleasure to introduce Professor Michele Lanza, Associate Professor of Ophthalmology at the University of Campania in Naples, Italy. Professor Lanza is a widely recognized clinician whose research spans many topics, such as corneal diseases, keratoconus, and ocular biomechanics. He has also authored more than 100 peer-reviewed publications, and today is covering the topic of cross-linking in keratoconus for us. Professor Lanza, the floor is yours. Thank you.
Thank you, Frederick, for your very kind words, and welcome everybody to these seminars where we are going to talk about cross-linking, how it is going to change the approach to keratoconus management. What is keratoconus? A brief introduction. Is a progressive ectatic disease where the cornea is going to lose its strength, so it's going to become thin, and the curvature of the cornea is going to increase because there is a biochemical failure that weakens the stroma and the strength of the cells. It is going to cause an irregular astigmatism with eye aberration that are leading to a reduction both in quality and in quantity of the vision. So it's very important to remind that it's going to hit the young patient. In fact, the typical age of the diagnosis is during around 20 years old. Is a very well-known disease, and for decades was absolutely contraindicated any kind of refractive surgery. We know that ectasia after PRK or LASIK could occur in case also of non-progressive keratoconus. So the options to manage this kind of patient were to use glasses and contact lens until the vision was acceptable for the patients. Otherwise, we had the option of corneal transplant, penetrated or lamellar one, for patients that were going to have a very, very thin cornea. And we did not have for many, many years a kind of procedure that was able to stabilize this disease. How was diagnosed? Because it's very important to stress this concept in the detection and management of the disease. In the 19th century, Javal keratometry was the only option available. Then in the early 80s of 20th century, the Placido disc topography was introduced, and it was a shock in this kind of topic because it provided for us a lot of very useful and detailed information. But something was missing because Placido disc topography was providing us information only about the anterior surface of the cornea. We were missing the pachymetry, we were missing the posterior part of the cornea. That in the last 90s was introduced the Orbscan slit scan device that was going to provide us information about the posterior surface of the cornea, but was still mixed with the Placido, so was not a sort of extremely new stuff that arrived some years later with the Scheimpflug tomography. And this is how were working these devices. On the left, you can see classic Javal tonometers. On the left, you can see how the mirrors were appearing in the physiologic cornea, and the distortion that could appear in the keratoconic corneas. With the Placido disc, Placido concentric circles were projected on the cornea, and on the right, on left here, you can see regular cornea with regular circles, and on the right you can see a normal cornea that show us an increase of the curvature in the lower part. And after elaboration through some algorithms, we were able to find where is how much was curved more this cornea, as you can see here in the classic topographic map. The orb scan had this slit scan that was scanning horizontally the corneal and was mixed with the placido, as you can see here. So the true anterior and posterior information were cut in some way, as you can see in this map on the both left. And so there was providing us a pachymetry, but was not something extremely new until we had the first Schemfluid device, that was the Pentacam. And it's important to remind that now there are also other Schemfluid device available, but Oculus has been the first to avoid the placido that was the gold standard for corneal diagnosis until the 90s. And now is the gold standard, is the current available device to use for every kind of corneal surgery. And here we can have a lot of different maps that we can select that show us information about the anterior, posterior curvature, about the pachymetry, and here there are all the parameters that we can immediately have. And also the easiness of the using of this kind of device has been a key factor of the success. But later we learned that the shape of the cornea was not the only stuff that was counting in this disease, because as we said, the cornea is going to lose his strength in this disease. So how we can measure the strength. And so in last years, the biomechanical evaluation of the cornea gained a lot of interest. And one of the first devices that was introduced, and the one that is currently diffusely worldwide used, is the Corvis ST, that is equipped with a Schemfluid camera that is going to, with the camera, sorry, not the Schemfluid camera, that is going to record the behavior of the air puff that is going to hit the cornea and modify this shape. So the camera is going to record the deformation of the cornea in a certain time and provide us a lot of parameters that are elaborated by the computer with proper algorithms, and they can be mixed with the morphological parameters to obtain new index like the CBI, the BID, the TBI, that show us that are very helpful in the detection of corneal disease. So let's do a step forward about the treatment. The first procedure described to stabilize the cornea in keratoconus, it is in the start of 2003 and was the known as the Dresden protocol, and as every one of us know, the cross-linking. What they were doing, they were irradiating the cornea with UVA after soaking them with the riboflavin, and it was very helpful. Was really a shock in the management of this kind of treatment, because until the 2000 we didn't have any option to stabilize the disease. We had to wait and pray for the progression, and pray that was not so much in avoid the corneal transplant. With this kind of procedure, the rate of the corneal transplant worldwide really decreased a lot, and there are a lot of paper in literature, a lot of study, a lot of communication in Congress that verify this in the worldwide. And the point was that after with the first protocol that was including 30 minutes of soaking of cornea and 30 minutes of irradiation, we were very happy as doctors, because we stopped the progression of the cornea, but patients were not. Why? Because after 1 hour of 1 hour of treatment, that was pretty painful, okay, because it was in topical anesthesia without the epithelium, and also the days after were not very easy to manage. The patient didn't gain anything. They were stable, and we as the doctors reached our goal. But every patient is always hoping for some improvement, but there is occurs very little modification in the visual quality in this patient. So the research tried to improve again the treatment. So how we did it? We had this protocol with the 3 milliwatts per centimeter squared for 20 minutes, with a total fluence of 5.4 joule for centimeters. And we started from this, and we tried to have an improvement that could be in accelerated the treatment, and to improve the compliance of the patient and to fasten the corneal recovery. But we still have many protocols regarding the improvement of the quickness of the treatment, show us that was efficient and safe as the Dresden protocol, and they were adopted worldwide. And also transepithelial protocols were tried. Pulsed cross-linking, iontophoresis cross-linking, slit lamp cross-linking, but we still were missing the key factor to the improvement of the quality and quantity of vision. Also, there are some protocols trying to include more patients as possible, but we had actual innovation when in 2014 Canalopoulos and Binder showed us the cross-linking plus, which is a mix between a cross-linking treatment combined with a refractive surface procedure. So we know that until then we cannot treat with a refractive surface procedure this kind of patient. Why? Because they have a weak cornea. So if we provide them such an energy, such the ones required by a PRK treatment, we were going to increase this weakness and cause an ectasia. But if we are going to reduce the treatment, so not aiming to erase the refractive defect, but to treat the aberration, so saving corneas, saving energy, and stretch the cornea with the cross-linking, maybe we can have better results. And this is what was proposed. After this first treatment, many other protocols were proposed that had the same day procedure, or the two procedures were performed after some months with transepithelial, topographic weighted. The wall was break, and everyone was trying new stuff. And actually, there was a key factor in every protocol that have been proposed and accepted in the international community: the progression. We have to have a detectable and reliable progression that provide us the information that it is something that we can treat with this kind of procedures, and which is the best way to detect it. The gold standard today is to perform a Scheimpflug tomography to evaluate the corneal shape, the whole corneal shape, anterior and posterior, and also all the alteration that we could observe. and biomechanics. This is going to give us all the holes in our puzzle in detecting the harder cases to manage. Maybe in future we will have also a brilliant microscopy devices that it seems to be promising, but is not so diffused now because it's technology not so reliable in big numbers. So we have to have a proven progression to apply one of these protocols. And this is going to change in some way the approach to this kind of patient. Because in the past we were detective progression to not perform the procedures, the refractive procedure. Now, if we have progression, we can, and we have, of course, all the parameters that allow us to perform safe combined procedures, we can say the patient, okay, you have keratoconus, okay, it's going slowly worsening, but we have an option. We can do this kind of treatment that is combined with refractive and cross-linking, but it's not a refractive that you know about, that some friend of you did with a simple myopia or minus two, and they did it, and bye-bye about the glasses. No, this is a kind of treatment that allow you to improve the quality of your vision, not to avoid the use of contact lens or glasses. And so, as I told you, many protocols have been proposed. Of course, they need to be accurately tested, because not everything that is new is going to be better, but there are some that are worldwide used, adopted, and tested with very, very good results. The first, as I said, was the Athens protocol proposed by Canelopoulos. The Cretan protocols and Cretan Plus protocols proposed by Kimionis and Grenzelos, and then the Tel Aviv protocol too, proposed by Rabina, and there is a contribution also from Italy with the Stair X protocol proposed by Dr. Rakikis and Mazzotta. And everyone is going to mix this kind of treatment, refractive and cross-linking, with some difference in timing, in energy, but the purpose is always this one: to reduce the aberration in a way to improve the quality of the vision of this patient, and then strengthen the cornea with the cross-linking. That can not be also the accelerated cross-linking that we were used to, because we have to be very gentle with the cornea, so the energy could be also high, but the duration of the treatment need to be very slow in order to not determine complication in this kind of eyes. Now there is a ray tracing that is going to be used in always more of this treatment, and this is a new option that we can have. And of course, with the improvement in the technology that we can apply in diagnosis and treatment of this eye, I guess that the future is always better for this kind of patient, and we have to always check the new treatment, because we need data that can be compared. We need the long-term comparison, long-term follow-up, and we have to be careful with this eye, because there could be some complication, and is important to take in mind that the safeness of our patient, of the cornea of our patient, is always our first goal. But this kind of treatment have been tested, and there have been a lot of comparisons also with cross-linking treatment alone. And as you can see here in this graph, there are an important gaining in visual acuity with or without correction. Of course, the results are very, in some way, unpredictable, because the cornea, the vision of this kind of patient, the physician that handle this kind of patient, this kind of cornea, know that their quality of vision is always very changing, also in months. But is be proven that it's very safe treatment and can provide improvement. So we can suggest our patient this option. And now there are many studies that can be adopted as a milestone to guide our customized treatment for our patient. And also with 3 years, as you can show in this, you can see in this graph, in 3 years follow-up, we are going to have a very, very good results also in terms of astigmatism. So let's come back. We can have very, very good results, but we have to respect some rules that are mandatory to avoid problems, complication, and ethical and legal problems. We have to do it in patients with progression. That means that you have to have an increasing of 1 or 1.5 diopter in the last 6-12 months, or reduction of 5% of the pachymetry, a myopic shift of at least 0.751 diopters, and increasing of the posterior elevation of higher than 15 microns in the last 6-12 months. So a brief recap: before, we could never imagine refractive surgery in this kind of patient. We just send them to the optic or the optometrist to have glasses, RPG lenses, or if the progression was too fast, we have to go to the transplant to avoid the corneal perforation. We have no way to stop the progression, and we have only a kind of optical correction, and as I said previously, to pray to not have a very fast progression. Now the future is in 2026 is always very different from 2003, where the Dresden Protocol was introduced, because now we have the possibility to stabilize, but also to provide a sort of visual rehabilitation for this patient, to improve the quality of their vision. But we have to respect all the rules that this kind of treatment, this kind of protocol needs to obtain a very good results. And this is extremely effective also because this kind of disease, the keratoconus, is going to hit the younger patient, and of course the visual penalization is going to limit a lot of their activity in study, sport, hobbies. Their quality of life will be biased by this kind of disease, because they hardly will reach the level of study, work that they want. So it's very important. It's very and there are some studies that show us that also the cost for the health system that were saved by this kind of protocols. So again, we have to detect the protection to start the cross-linking and or cross-linking plus discussion. And of course, we need very reliable, accurate device. And the gold standard today is use the chamfer camera in combination with the corneal biomechanical detection. And of course, the combination of Pentacam and Corvis ST is absolutely the best to do it. Some cases to show you how to use these devices. This is a case of a very easy progression to detect. As you can see here, we have the topography done in May and the one done 5 months before. You can see that there is an increase in the parameters, okay, that show us the increase of anterior corneal curvature, okay, and also the differential map is going to show us that there is a progression in the curvature, okay, and also in posterior map you can see that there is some shift. And also, if the pachymetry is not going to be so much reduced, this is a kind of eye that we can all consider in a status of progressive keratoconus. So they could be involved in a cross-linking treatment. And because we are very good in this case, because we did an early detection with a pachymetry that is 489 microns in center and 464 microns in the thinnest one, we can use this 64 micron to reduce the aberration of this eye. Let's go to a progression is a bit harder to detect. There is a very young patient that is 18 years old that came to us some years ago, and she was complaining about reduction of his quality of vision. Not so much about the quantity. The level of vision was always the same, but he was always complaining about the progression of the reduction of the quality of vision. If we see the comparison of the map after 4 months, we'll see not so much different, okay, in the corneal shape. The differential map is going to not providing us any tips in progression, and also if we see the parameters, there is not so much about progression here. But this continuous complaining about the quality of vision and the very young age of the patient pushed us to do something more, and we did a Corvis 2, and we analyzed the parameters related to the corneal biomechanics. And you see here that we had a BD of 4.96 in the first cases, and after 4 months, we had a very high BD. So this was a progression that was first starting in the structure of the cornea, okay, in the biomechanics, and then in the morphology. So we shortened the follow-up. After 1 month, we repeated the topography, and we detected the progression in the cross-linking. What is going to happen after the cross-linking plus? This is a kind of results that you can observe after 1 month, and here you can see fundamental stabilization of the anterior surface of the cornea, okay, without problems here, okay. But after 12 months, this is another patient, and as you can see here, this was in December 2005. This was almost one year after the treatment that was done in the end of January. And you can see that we have very stable results with no ectatic problems in these eyes, because of course we are very worried to be safe in this kind of patient, and so we are providing them in their cornea a much more level of energy that need to be accurately studied to avoid complication. And this is another case after 1 year. You see February 25 and February 26, and you see in these cases a better amount of corneal reshaping, reducing the level of corneal curvature. And here is very clear here in this differential map. Sometimes there is stabilization with a bit of increase in quality of vision. Sometimes we have very, very good increase, as you can see, in flattening the cornea and improving the quality of the vision. This is a very interesting case that I want to show with you. That is cases after 6 months of cross-linking plus. Disaster or not? Let's see. Here is the pre-op topography. Okay, November 2005. We did this after 10 days, and this is the very recently exam that we did in last month. Okay. If you see here, we did a disaster because we increased the astigmatism of 2.8 diopters. But let's see better, and this is very interesting about this kind of technology, this kind of device that provides us all the information that we need. What we had here, we had a corneal curvature that was very, very steep in his apex, in the inferior part of the cornea, and compare with the superior one. So here you had a very, very regular astigmatism, and the quality of vision of this guy was very low. In these cases, what we had? We had a reduction of the inferior curvature and an increase of the upper curvature. So this kind of astigmatism was still an irregular astigmatism, but was less irregular of the pre-op one. So the patient was extremely happy because he couldn't wear the contact lens too. Instead, with this condition, he was having a very good vision, also only with glasses, and with the contact lens was extremely happy. So we really improved his quality of life. And here is very good in the differential map how we had an increase of the curvature in the upper part of the cornea, showing that our goal is the regularization, because the irregular astigmatism is the problem in these eyes. Is going to bias actually the quality of their vision. If we make it regular, also if it's higher, they are going to see better and are going to be very, very, very happy. And this is the axial map that shows us the same concept with this other map. What we have to remind that now we can act to improve the quality of vision of this patient with keratoconus, with something that was forbidden 20 years ago, okay, with the refractive surgery. We started from the Dresden protocol, and now we use the cross-linking to strengthen the cornea and make the cornea able to receive the energy of the excimer laser to reshape the corneal, aiming to erase the high-order aberration and increase the quality of life. Can we use it for every patient? No, we have to have a very reliable instruments to evaluate the patient before and after to be sure that we are doing the best for our patient.
Thank you very much, Professor Lanza. To me, it was very enlightening, and I guess my main takeaway is that there's a lot of hope for patients out there that are suffering from this life-changing disease through personalized treatment. Now, I have a couple of questions for you on this topic. I wanted to know, after treatment, how long does it take for you to follow up, in terms of follow-up, to consider that you have a successful treatment?
This is a very interesting question. Thanks. They become part of my family, actually, because we are following them. We know that cross-linking is going to stop the progression, but not always. Sometimes we are going to see a progression, a failing of the treatment after 3 or 4 years. Okay, so we always follow this patient every 6 months. The one that we do standard cross-linking and the ones that we do cross-linking plus. They start thinking about the improvement after 3 months, because before this kind of time, the cornea is still in reshaping. Actually, we consider the, let's say, stable results after 6 months, also if there could be some little changes also after 6 months. So we don't stop to follow them, and we say them that we could achieve some reliable results between 3 and 6 months after the treatment.
Okay, very good. My second and final question is: would you treat an eye with normal vision but high tomographic and corneal biomechanics risk for keratoconus?
If I see, we did it when we saw a progression, because you know, the vision, the final vision, that is something that the patient is going to refer. Okay, there are patients that see 20/20 are not happy. There are patients that see 20/40 are happier. Why? Because of their quality of the vision. And we have to be very careful with this concept, because we have to be able to detect the start of the worsening of the quality of vision. That's why we need all the information as we can get, both for the morphological side and both for the biomechanical side. Because, you know, it's always about to talk with the patient. Because we say, okay, now you have a good vision, but there is something that is moving in your cornea. So probably, I don't know, in 1, 3, 6 months, is going to worsen. Now, if it's going to worsen, we can try to get back your vision with a cross-linking plus. But I don't know how much is going to worsen in 6 months. Because maybe in 6 months, you will not be able to do a cross-linking plus. We should be able only to do a cross-linking. So only to stop, not to come back to a good quality of vision if you just had the worsening. I don't know if I'm clear.
Yeah, that was clear. Perfect. Thank you very much. Yes, you have one more thing, yes?
Yeah, that's why it's important to have follow-up, regular follow-up that show you the possibility to treat or not to treat.
Okay, perfect. That was clear. Thank you so much, Professor Lanza, for your time. And thank you, everyone, for attending. And we shall see you later. Thank you. Goodbye.
Thank you so much. Goodbye.